Hi everyone, welcome to Research MD. This is Dr. Pramil. I work as a program director, internal medicine residency program as chief medical officer, also an associate professor of medicine. Today, we're going to continue our lecture series on in-service training examination, hard topics. This could help you to score extremely high in internal medicine training exams, which is given once every year. A lot of people don't take it very seriously. So let's start. Today we're going to continue a rheumatology topic. The question is about dermatomyositis management, okay? So let's start with the question first. A 45-year-old person with a proximal muscle weakness, heliotrope rash, Gauthron's papule, elevated CK, EMG showed myopathic changes, okay? Which of the following is the most appropriate initial treatment? You got four choices up here: methotrexate, azathioprine, IVIG, and prednisone. Okay, so answer is prednisone. High dose corticosteroid is the number one first line treatment for dermatomyositis. Okay, it can combine with immunosuppressive agents if it is refractory cases. Okay. Now, pathophysiology, let's look at dermatoma, idiopathic inflammatory myopathy. There is inflammation, okay? Pathogens involved, immune-mediated muscle change. It's kind of linked to malignancy and autoimmune disorders. Classic skin finding, they can even put a picture of the skin finding, heliotrope rash, Gauthron's papules, and patients usually photosensitive. Now, diagnostic clinical features. The main thing, proximal muscle weakness. So how do you define proximal muscle weakness? Somebody's going to say patient has proximal muscle weakness. The examination is going to say patient cannot get up from the chair, or so lifting arms to comb the hair, those kind of signs of proximal muscle weakness. If we talk about the skin finding, heliotrope rash and Gauthron's papule, in the CK and aldolase will be elevated, anti-Jo1, anti-M2. Confirmatory test is EMG can do, which say myopathic changes, muscle biopsy, inflammatory infiltrates. So first line of therapy, we already said, high dose steroids, and adjunctive therapy, that's the word if you're immunosuppressive agents, methotrexate, azathioprine, IVIG for severe or very refractory cases. Additional, always look for malignancy is very common in these people, okay? So next question, a 60-year-old with a dermatomyositis person with a progressive muscle weakness despite corticosteroid treatment. He also noted to have interstitial lung disease on imaging. Which is the most appropriate next step in management? Increase corticosteroid dose, add methotrexate, start IVIG, perform muscle biopsy. Despite corticosteroid, the word here is despite corticosteroid. So what's our next treatment? Okay, the treatment is add methotrexate. Methotrexate is a steroid-sparing agent, remember. Okay, especially patients who have interstitial lung disease. Now, another question. 65-year-old man with dermatomyositis, muscle weakness, joint pain, dysphagia, interstitial lung disease, started high-dose steroids and methotrexate, symptom persists, considered for second line of therapy. Which of the following is the most appropriate for this patient with refractory dermatomyositis and lung involvement? The word is refractory dermatomyositis and lung involvement. You got rituximab, cyclophosphamide, IVIG, azathioprine, and hydroxychloroquine. So the answer is rituximab. Rituximab is the second line of treatment for refractory dermatomyositis, especially in patients with the interstitial lung disease. It works by depleting the B cells, which is involved in the pathogens of autoimmune diseases like dermatomyositis, okay? So let's look at next question. A 40-year-old diagnosed with dermatomyositis, you got classic heliotrope rash, Gauthron's papule, who was given prednisone, developed with significant weight gain, osteopenia, hypertension. Which of the following medication can be reduced to the need for prednisone and manage your muscle weakness while minimizing the side effect? Methotrexate, rituximab, azathioprine, mycophenolate, mofetil, and hydroxychloroquine. So the answer is azathioprine. It's an immunosuppressive agent. Can be used as an adjunct therapy to reduce the need of high-dose steroids. Dermatomyositis, again, inflammatory is the word, high-dose corticosteroid, and then steroid-sparing drug, immunosuppressive agent, IVIG, azathioprine, and all of this have the other role in it, okay? Thank you so much for watching. We'll be back with another presentation soon.